Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome back to another power packed session of AMCI CPT Guideline Mastery Sessions. Okay, hi, Miss Mills. Thank you for letting me know, Miss Mills, that my mic is good. Okay, hi, Catherine. Hi, Miss Veena. Hi, everyone. Who else are there with us? Hi, Swelton. Hi, Patty. Hello, welcome everyone. So I have placed a poll question in the on the screen. You can see how confident are you in catheterization procedure from the cardiovascular system. Let me know, coders. Are you very confident? Are you feeling moderately confident, or somewhat confident, or not confident at all? Let me know. Hi, Beth. Hi, everyone. I can see a lot of familiar names in the chat. Welcome. So let me know in the chat, coders, how are you feeling about coding these catheterization procedure? Okay, so I hope you all are feeling good, energized, motivated, and ready to sharpen those coding skills today. So during these CPT guideline mastery sessions, each week we focus on one topic, we dissect them, the key guidelines, and work through the practical examples so you walk away not just informed but feeling empowered. So stay engaged, keep your CPT book open, take notes, ask questions, and most importantly, enjoy the learning process. Okay, all right. I can see some answers, some responses. Okay, good, good. Okay, fine. No worries at all. Yeah, if you're not feeling good with this procedure, we are going to master them today. All right. So I will just stop the poll and I will hide it. Okay. All right. So let me first of all read out the copyright before we move on. CPT copyright 2026 American Medical Association, all rights reserved. CPC is a registered trademark of AAPC. The AAPC content found within this presentation is a copyright of AAPC. The keyword concept FDR churn, AMCI FAB 7, AMCI ICD 10, flip tab, and MCG are the trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPP, MCP, CO are owned by AAPC. AMCI do not own right to these credentials. All right, the credentials CCA, CCS, CCSP, RHIA, RHIT are owned by AHIMA. AMCA do not own right to these credentials. All right, I can see the answers are coming now. I understand that my screen is a little bit slow, so I will get your responses off only after a couple of seconds. Okay, so thank you everyone for putting your response in the chat. And today we are going to learn about one of the most demanded, I would say, yes, and highly requested topic among the students. And I've seen students asking for a session on these topic, even filling out the survey forms. Okay, so this topic that has this is a topic that many of you have been waiting for. And honestly, when I was preparing for my exam, I was also looking forward to understanding this properly, because at first it can feel a little bit confusing. There are vessels, there are pathways, levels, a lot going on, right? And cardiovascular system, at times, sometimes there is a chance that you will feel a little bit overwhelmed. So the good news is that AMCI breaks this topic down so beautifully and logically that once you understand the concept, everything just starts to click. Okay, so today the focus is going to be on the catheter placement and cervicocerebral angiography coding. And before we begin, let's take a moment to understand where to find these codes which we are going to review today. So for today's session, we are working with the cardiovascular system. It's a week 3 here at AMCI, and this cardiovascular system falls under the surgical chapter in your CPT manual, as you all know. And today's focus will be on catheter based procedures. Specifically, there you will find these codes under the header, the subsection vascular injection procedure. Okay, so we will begin with the cervicocerebral angiography. All right, Coda. So before we jump into the codes, let's understand the concept first. Okay, today we are talking about the cervicocerebral angiography. This is a minimally invasive diagnostic procedure where a catheter is actually inserted into the blood vessel, and then a contrast injection will be injected, and imaging is performed to visualize the neck, the vessels of the neck and the brain. Okay, and this procedure is generally considered as a gold standard for evaluating these blood vessels because it allows the physician to see the vascular anatomy in extreme details, even at sub-millimeter level. Isn't it great? Yes. So what are we actually looking for? We are looking for, or with the cervical cerebral angiography, the physicians can identify a neurism. Otherwise, they are the bulging vessels, and it's a very serious condition. And blockage or clots, narrowing, which is stenosis, as well as vascular malformation. So this is the purpose of having a cervical cerebral angiography. And the term cervicocerebral angiography refers to the major blood vessels supplying the neck and brain. So these vessels are critical because they deliver oxygen rich blood to the brain and the spinal cord. So there are two main arterial systems that form this network, and it's very important to know these. Okay, the first one is carotid system, and the second one is the vertebral system. Now that we understand what a cervicocerebral angiography is, let's take a closer look at two major arterial systems which I have said. Let's start with the carotid arteries. Okay, the carotid system is actually responsible for supplying 80% of the brain blood flow. So it plays a major role in cerebral circulation, right? And the main vessels here are common carotid arteries. So over here, let me take my pointer. Okay, I'm not able to find. All right, just give me a moment. Okay, I'm not able to find my pointer. Yes, I got it. So, okay, here we go. So you can find the common carotid arteries over here, and here. So there are two branches, one on the right and the one on the left. They arises from the chest and divides in the neck into internal and external branches. Okay, so we can see over here. Yes, these are your internal and external branches, or internal or external carotid artery. So internal carotid artery actually enters into the skull and supply the anterior and lateral part of the cerebrum, while external carotid artery supply the blood to the neck, face, and scalp. Okay, and next, the second important territory is the vertebral arteries. So they provide about 20% of the brain's blood flow and supply to the posterior structure. So they originate from the subclavian artery. Over here you can see, okay, let me just click here. Okay, and yes, you can see this is the subclavian artery, and vertebral artery actually begins or branches off from the subclavian artery. Okay, so as I said, the vertebral artery actually branches off from the subclavian artery, and then it moves upwards. As they ascend, two of the vertebral arteries will eventually come together at the base of the brain to form a single vessel called as basilar artery over here. So you have vertebral artery coming from your right side and left side, and they will join together to form a basilar artery over here. And basilar artery also plays a crucial role in supplying brainstem and cerebellum, which are essential for the vital functions like balance, coordination, and basic support. Okay, so that about the two arteries. Now we understand the vessels involved. Let's take a moment to understand how the procedure is actually performed. So, cervicocerebral angiography, as I said, is a minimally invasive procedure, and this process starts with the insertion of a thin tube called as a catheter, which usually is introduced through the blood vessels in the leg. And most commonly, we use a femoral artery over here. Okay, and this will serve as an entry point into the arterial system. And from the femoral artery, the catheter is carefully advanced upwards the vascular system until it reaches the aorta. See, and this is a main artery coming out of the heart. So once a catheter reaches the aorta, it is then selectively guided into vessels that supply to the head and neck. It can be carotid or vertebral arteries. So after the catheter is positioned into the desired vessel, a contrast dye is injected. And this dye travels along the blood flow and it helps to outline the vessels. So after that, an imaging is used and the physician can observe how the dye flows through these arteries, and a detailed view of the vascular anatomy is obtained. So this allows for accurate evaluation of the carotid and vertebral system and helps to identify any abnormalities like narrowing, blockage, or aneurysm. So in simple term, catheter is inserted, advanced to the aorta, then selectively directed into the targeted vessel. Contrast is injected and imaging is used to visualize the blood flow. And this entire process forms the foundation of the codes we are about to study today. All right. And this is how the image looks like. Isn't it amazing? Yes. So the physician will be able to find out if there is any aneurysm or any blockade over here. All right. So let's move on to the next slide. Now, coders. In medical coding, the vascular procedures or the catheterization is broadly classified into two types. One, non-selective, and the other one is selective. Okay, and it's very important to know what a selective catheterization and a non-selective catheterization, because you will be hearing more about these procedures or these terminologies in the upcoming slides as we move forward. So let's start with the non-selective catheterization. And in non-selective catheterization, the catheter is actually inserted and advanced into the aorta, and it will remain there in the aorta. Other words, the catheter does not enter any specific branch vessels. It says it stays in the main artery, and then imaging is performed from that level. So if your catheter is inserted into the aorta and it remains there, it will be, or it is known as a non-selective catheterization. Okay, now let's move on to the selective catheterization. In selective catheterization, the catheter again reaches the aorta, but instead of stopping there, it is further guided into specific arteries beyond the aorta, such as your carotid arteries or vertebral arteries. So this allows a physician to study particular vessels in detail and provide more precise and targeted imaging. All right. So let me know, coders. Is this clear? Let me know in the chat because it is very, very important to know. So are you clear about the difference between what's a non-selective catheterization and a selective catheterization? Let me know in the chat. Okay, so it will take a couple of seconds for me to see your response. Okay, thank you. Thank you for letting me know, Sheila. All right, so meanwhile, I will move on to the next slide. And there are two important code ranges we will focus today. The first one is 36221 through 36228. And the second one, okay, so 36221 through 36228, these codes are specifically used for diagnostic studies of the cervicocerebral arteries. And this includes the vessels of the aortic arch, carotid artery, and vertebral arteries. So whenever we are dealing with the imaging of the blood vessels supplying to neck and brain, this is the code family we are going to use. And the second group is 36215 through 36218. And these codes describe selective catheter placement into the thoracic or brachiocephalic branches. And in this case, the focus is more on how far catheter travel in the vascular system rather than the imaging of the brain circulation. All right. So 36221 to 36228 is mainly for diagnostic studies, and imaging will be done over there, while 36215 to 36218 it deals mainly with the catheter placement alone. Okay, so students often get confused between these two code series. Now let's take a step back and understand overall code family from 36221 through 36228. So these codes describe selective catheter placement and diagnostic imaging of the aortic arch, carotid arteries, and vertebral arteries. And these codes are comprehensive, meaning they include placement of the catheter, they include the injection of the contrast, the fluoroscopy performed, as well as radiological supervision and interpretation, and even the closure of the access site, whether it may be by pressure or closure using some device. Okay, so everything performed or everything involved in performing and interpreting the study is actually bundled into these codes, and you should not report them separately. And another key concept is that these codes follow a progressive hierarchy. So, what do you mean by a progressive hierarchy? So, as we move from 36221 to a higher level code, maybe 36222, 36223, these services become more selective and more intensive. And each higher level code already includes the work of lower level services. So if you're performing a selective catheterization, you should not report 36221, because the selective catheterization code already includes a work for accessing and imaging the imaging of the aorta. So I will explain much more with the help of the codes. So the first code is 36221, and this code is used for the angiography of the carotid and vertebral arteries without selective catheterization of the great vessels. So as you can see from the code language itself, it means that this is a non selective catheterization, right? Yeah, the code language clearly says this is a non selective catheter placement, and the catheter won't be leaving the aorta over here. All right. Also, golden rule coders, remember that you cannot code a non-selective catheter placement code with a selective catheter placement code. All right. So 36221 is for non-selective catheter placement, and the remaining codes under this group is for selective catheter placement. So you cannot code them together because the work is already included. Okay. And the next code would be 36222. This code and for I would say the remaining codes are actually classified based on two things: where the catheter is placed and what level of imaging is performed, if it is extracranial or intracranial. All right, so 36222, this code is when the catheter is selectively placed into the common carotid artery or innominate artery, and the imaging performed is actually limited to extracranial carotid circulation, meaning they are only looking at the blood vessel that is outside the skull. Okay, extracranial, that means outside the skull. Now moving on to the next one, 36223, the catheter is placed and remains in the same place. It's the same common carotid and innominate artery, but it is still but the difference is in the imaging. So for 36223, it includes the intracranial carotid circulation and extracranial carotid circulation imaging. Okay, so three, or the only difference between 36222 and 36223 is that 36222 is only coding for an extracranial carotid artery imaging, while 36223 is coding for both intracranial as well as extracranial carotid artery imaging when performed. Now let's look into the next code, that is 36224. Here the catheter is advanced further and it is placed into the internal carotid artery, so it moves further, all right, and the intensity and the complexity also increase. So here this is more selective and deeper level of catheter placement, and the imaging again includes the intracranial circulation along with the extracranial circulation and arch imaging when performed, all right. And this is the hierarchy which I was talking about. The first would be, or most severe or most complex procedure would be 36224, and that includes all the work done at 36223 and 36222. So if you have all the three, you should not report these three together for the espilateral angiography. That means for the same side, when angiography is performed on the same side. And you have to select only one code that is representing the most comprehensive or most complex physical service, then that would be 36224. All right, coders, let me know. Are we good so far? Are we good? Okay, thank you. Thank you for letting me know. Are we good so far? Because we are moving into the vertebral territory or vertebral system. And there are two codes under vertebral territory, that would be 36225 and 36226. So just like the carotid codes, the logic here is the same. We need to focus where the catheter is placed and what circulation is being imaged. So let's start with 36225. So in this case, the catheter is selectively placed into the subclavian or innominate artery, and from this position, imaging is performed of the vertebral circulation, which supplies to the posterior part of the brain. So here catheter does not directly enter the vertebral artery, but the imaging of the vertebral system is still achieved. Now moving on to 36226, this is a step further. Here catheter selectively advanced directly into the vertebral artery itself. And this represents more selective and deeper level of catheter placement compared to 36225. So 36226 is more complex than the 36225, and this is a hierarchy which you have to follow. And if you have both done for the espilateral, you have to select only the most complex, that would be 36226. And then we have the add-on codes. The add-on codes are 36227. There are two add-on codes used in this code range, that is 36227 and 36228. So add-on code 36227 is used when catheter is selectively placed into the external carotid artery and imaging of external carotid circulation is performed. So remember, external carotid artery means that it doesn't supply the brain, supply to the brain. It supply outside the brain. That would be the face, scalp, neck structures, etc. And importantly, this code is used in addition to the one of the primary carotid codes such as 36222, 36223, and 36224. So you can find them in the parenthetical guideline over here. So make sure when you're using this add-on code, you use with only with these primary codes. All right, and the next one would be 36228, and it involves a catheter placement into the intracranial branches or the intracranial carotid artery or the intracranial or the vertebral artery, and it is not reported more than twice per side. That is another important thing which you have to care about 36228. You cannot code more than twice per side, regardless number of additional branches or selectively catheterized. Okay. All right. Let me have a look into the chat. Great. And let's move on to the next one. Now let's talk about another guideline or another important concept about the bilateral procedures. So in many cases, physicians do not just study one side. So you can see there are two sides, right? One on the right and one on the left. And they may perform catheterization and imaging on the both right and the left side of the carotid or vertebral artery. So the question is, how do we know that? Or how do we code that? Sorry, how do we code that? So for the primary codes, you use 36222 through 36226. Rule is straightforward. If the same procedure is performed on the both side, we report the code with modifier 50. So your primary codes are 36222 through 36226. So you will report them with a 50 modifier. Now, if there is an add-on code used, you cannot assign 50 modifier to the add-on code. Instead, you would report the add-on code twice, the 36227 and 36228. You have to use them twice because you cannot assign a 50 modifier with the add-on codes. Okay, now let's look into the another important guideline when different vascular territories are studied during the same session. So up to now we discussed about the bilateral procedure. So when the same study is performed on the both study, we use 50 modifier as I said. But what if the procedure are not same on the both side? Like in some cases, physician may study different arteries on each side. For example, internal carotid artery imaging on one side and common carotid or vertebral imaging on the other side. So in this situation, we are not dealing with the identical bilateral services anymore. So instead of using 50 modifier, we use 59 modifier under these circumstances to indicate that these are distinct procedural services, meaning they involve different vascular territories. All right. So that's about your 50 modifier guideline and the 59, when to use a 59 modifier. Okay, now we have completed the cervicocerebral angiography codes. Let's move on to another important group, that is 36215 through 36218. And this set of codes is focused on selective catheter placement within the thoracic or brachiocephalic branches. And unlike the previous code family, these codes are not about imaging. They're all about placing the catheter or catheter placement. And here our entire focus is on how far the catheter travels in the vascular system. So as the catheter is introduced and advanced from the access point, it moves through different level of vessels. And these levels are actually classified as first order, second order, and third order branches. So the closer the vessel to the aorta, lower the order. Okay, so the catheter, as a catheter moves deeper into the branches or branching vessels, the order increases. And let me explain with the codes. So you have 36200, and that is for interaction of catheter into the aorta. And you know that by the definition, 36200 would be qualifying for a non-selective catheterization because the catheter is not going beyond the aorta, right? Yes. So this qualifies for a non-selective catheterization. So once the catheter leaves the aorta, the first branch that would be first order. You can see the brachiocephalic. That is going to be a first order. All right. And if the branch, it further branches, the catheter moves into the next branch, that would be, for example, here you can see the common carotid artery, and that would be your second order. And you have the codes for the first order, that would be 36215, 36216 for the second order, and then we have 36217 for the next branch, that is the third order. And 36217 is for third order or more selective thoracic and brachiocephalic branches. So even if it is a fourth order, you will code for 36217. And we have add-on code 36218 for any additional second order or third order beyond the thoracic or brachiocephalic branch. So if any other branches catheterized, you would code for 36218. Okay. All right. So now at this point, you might be wondering, there are so many arteries in the body. And how are we supposed to know which one is the first order, the second order, and the third order, right? Yes, that is a valid question. And this is exactly where the Appendix L in the CPT book come extremely helpful. So Appendix L provides clear visualization or visual classification of arterial vascular families. And it also shows how the vessels branches out from the aorta. And it helps to identify the order of each vessel based on the relationship to the aorta. So instead of trying to memorize each artery, the Appendix L is the vascular branching model uh, that assumes the aorta, vena cava, pulmonary artery, or portal vein is the starting point of the catheterization. And in the Appendix L, when you open it, if you have your book or the CPT manual, you can go and open the Appendix L now. So you will see that it is divided into two main sections. One section is showing the arteries that is above the diaphragm, and the other one shows arteries which is below the diaphragm. And we use the Appendix L as a reference guide to understand the hierarchy. So why is this division important? This division is important because it helps us to quickly identify which code family to use based on the regions we are working on. So this is the Appendix L for arteries above the diaphragm. And the arteries above the diaphragm includes the thoracic and brachiocephalic vessels, which are relevant for the codes 36215 to 36218. So you can see 36215 for the first order, 36216 for the second order, 36217 for the third order, and 36217 for the orders like the other branches after the third order. Okay, even if it's a fourth order, also you will use 36217. Okay, and for the arteries below the diaphragm, it includes abdominal and lower extremity vessels, which falls under the code range 36245 to 36247. So for 36245 is for the first order, 36246 is for the second, 36247 is for third order and beyond. All right, great. How are you all feeling, Chorus, so far? Let me know the chat. Okay. So these are the codes which I've just mentioned. You have 36200, that is for non-selective catheterization. After that, you have 36215 to 36218, that is for the catheterization above the diaphragm. Then we have 36245 to 36248, that is for catheterization below the diaphragm. Okay, and yes, so this is another visualization of what I've just said. On the one side, you have the thoracic and brachiocephalic catheterization core, and the other side you have abdominal, pelvic, and lower extremity, which is below the diaphragm. And uh, y- remember, coders, you will have to only code for the highest order or highest branch in which the catheter reach. So if the catheter moves from the first order to the second order to the third order, you will only code for the third order. Okay, you do not need to code for the second order or the first order. So always code for the highest order or highest branch in which the catheter stops. Okay, so that's all about the instructions on the catheterization procedure. So these are the FTR. So if you have our AMCI MCG 2026 manual or even 2025 manual, you will find these FTR. So these are the facts to remember, and you know how the guidelines are broken down so simply, so in a such a simple way. Okay, so when you have those catheterization procedures, first thing you have to see, is it a selective catheterization or a non-selective catheterization? That should be your first question. Second one, whether it was upper or lower diaphragm procedure. Third one, first, second, third order. That's your vascular order. Okay, that's your hierarchy. Not hierarchy, that's your vascular order. Code the highest order. Fourth point, Use appendix L to identify vascular families, and the code series which would be helpful through appendix L is 36215, 36218, and 36245 to 36248. So only these code ranges you will find appendix L more beneficial. And for 36221 through 36228, angiography and radiological supervision and interpretation are bundled. You can use 50 modifier. You have the 50 modifier guideline. Use 50 modifier for bilateral arteries, and use 59 modifier for different arteries or different territories. Okay, so it's pretty much simplified in our MCG manual. And let's do some exercise. Okay, let's try to break down, or let's try to implement what we have learned so far. Are you ready, coders? I know you all are. And let's begin our first question. Okay, so I will start the timer, by the way, so that we can complete the session within the 1 hour time which we have. Of the following answers, which best describe the service? Option A, 36222. Option B, 36223. Option C, 36224. Option D, 36224, 36221. A physician performs selective catheter placement into the right internal carotid artery. They perform angiography of epilateral intracranial carotid circulation as well as extracranial carotid and cervical branch or cervicocerebral branch. Uh, of the following answers, which best describe the service? And Chorus, you got 2.5 minutes. Your time has already begun. Place your best answers in the chat. So let's participate, and don't worry, even if you get it wrong, we are going to solve it together. Okay, so place your answers in the chat. Go ahead, Goddess. Awesome, awesome, awesome. Great, great answers. Great answers. All right. So let's go ahead. Let's break this down together. So if you're still working on it, coders, please go ahead and place your answers in the chat. Okay. So let's have a look. Let's first have the inventory. In inventory, we have selective catheterization performed, right? And it was done, the catheter was inserted into the right internal carotid artery, and then an angiography procedure was done. So angiography of intracranial carotid circulation, extracranial carotid circulation, and cervical cerebral branch, cervicocerebral branch. Okay, cervicocerebral arch was done. All right, so this is what we have in our inventory. Now let's look into the codes. 36222, option A, is coding for selective catheter placement into common carotid and innominate artery, as well as 36223 is also coding for catheter placement into common carotid or innominate artery, right? So these are coding for a wrong catheter placement. or a wrong area of where the catheters were inserted. We have a much more complex catheterization or catheter placement. So it went further ahead and placed the catheter into the internal carotid artery, right? So that makes option A and option B both incorrect. So both wrong because of wrong catheterization or catheter placement. We are left with option C and option D. Uh, Both are coding for 36224. That is for selective catheter placement into the internal carotid artery. So yes, we have catheter placed into the internal carotid artery. And now next, let's look the angiography part. So angiography was done for the internal cranial, intracranial carotid circulation, extracranial carotid circulation, and cervicocerebral arch. So all these three are mentioned in the CPT code 36224. So it looks like a good code selection. And option D is also coding for 36221, which is for a non-selective catheter placement. And do you know why coders I can say option D is wrong? Can you say the guideline? Yes, the golden rule which we are talking about, right? Never report 36221 in conjunction with the selective codes, that is 36222 through 36226. And you can find that in the parenthetical guideline here as well. Do not report 36221 with 36222 through 36226 because 36221 is a non-selective catheterization code. Well, remaining are rest of them are for the selective catheterization, so you cannot code them together, and that makes the option D incorrect. And the correct answer, as most of you have said, most of you have went with option C. Fantastic job, great job, coders. Excellent. Yes, you are absolutely correct, Miss Veena. Great job, coders. Well done. Let's move on to the next one. Okay, here we go. The second question. We'll start the timer. Of the following answers, which best describe the service? Option A is for 22150 modifier. Option B 36222. 36222 modifier. Option C 36222 with a 50 modifier. Option D 36223 with a 50 modifier. A patient underwent a diagnostic angiography. The physician accesses the femoral artery and advances a catheter into the aorta. Then selective catheterization of both right and left common carotid arteries is performed. Bilateral extracranial carotid angiography is performed showing minimal tumor blush with no additional abnormalities. Of the following answers, which best describe the surface? Encoders, your time has already begun. You've been doing a great job. Okay. So, all right, good. I can see some great answers coming along. Okay, good job. So, once again, let's break down this scenario. We have in the inventory, we have selective catheterization done. Okay, so the catheterization done in both the right and left common carotid arteries, right? It's done in the both side. And again, a bilateral extracranial angiography was also done. So that is what we have in our inventory. Now it's time to look into the codes. Option A is coding for 36221, and 36221 is coding for a non-selective catheter placement, right? So non-selective catheter placement means the catheter stays in the aorta and it doesn't goes beyond the aorta. All right. And in our scenario, was the catheter just placed in the aorta or did it went beyond the aorta? I can see from the scenario, from the documentation, that it reached the catheter, reached the aorta, right? And after that, it was selectively catheterization was done into both right and left common carotid artery. So it went beyond the aorta. So it is not going to be a non-selective catheter placement. It is going to be a selective catheter placement. And we have mentioned that in our inventory as well. So option A is wrong. It's coding for a non-selective catheter placement. And next we have option 36223, which is option D. Now that is coding for a selective catheter placement into the common carotid or innominate artery. So that's good. But 36223 is coding for both extracranial angiography as well as intracranial angiography. Am I right? Yes, it's coding for both angiography. And well, we didn't had both intracranial and extracranial angiography, correct? Yes. So we had only extracranial angiography, and that makes option D incorrect. Yes. So intracranial angiography was not done. Also, now we are left with option B and option C. So option B is coding for 36222 twice with a 59 modifier. And from what we reviewed from the guidelines said that when bilateral carotid or vertebral artery catheterization and imaging is performed, we have to use the primary codes 36222 through 36226 with a 50 modifier. So we had a bilateral procedure here performed, and it was the same angiography done in the both sides. So you have to use a 50 modifier in this scenario, which eliminates option B, and option C is going to be your correct answer. Okay, how are you all doing, coders? Let me have a quick look into the chat. How are you all doing? A is for a non-selective catheterization, so that's why A is incorrect. Okay, all right. Let me know, coders, how are you all doing? So meanwhile, I will move on to the next one. Exercise number 3. Of the following answers, which best describe the service? Option A 36224, 36222 modifier. Option B is a 36224 with a 50 modifier. Option C 36222 with a 50 modifier. Option D 36223, 36222, sorry, 36222. A physician performs selective catheterization of the right internal carotid artery with the right extracranial and intracranial angiography. During the same session, physician also performs selective catheterization of the left common carotid with the left extracranial carotid angiography. Of the following answers, which best describe the service? And your time begins now, coders. Apply the guideline which you have learned. Okay. Okay. Once again, great answers, amazing answers in the chat. So I will up the pace a little bit so that I have two more scenarios to cover, and I will try to complete. Okay, so this is what we have here. We have in inventory a selective catheterization done at the right internal carotid artery, and a right extracranial and intracranial carotid angiography was done here. Also, we had the same session, we had selective catheterization of the left common carotid artery, and the only left extracranial carotid angiography was performed. Okay, so procedure is performed on both sides, right and left, but both are different procedure and both are of different territories. One is on the right internal carotid artery, one is on a left common carotid artery. So both are different territories, right? Different locations. Okay, so 36224 is coding for option C. 36 option B 36224 is coding for selective catheter placement into the internal carotid artery, and it's coding for angiography of intracranial carotid circulation, extracranial carotid circulation, and cervicocerebral branch arch if when performed. All right, so this is for a bilateral procedure, option B. Now, in the other laterality, we didn't had a intracranial carotid angiography, right? We had only left extracranial carotid angiography done. So that means you cannot code for uh, option B, because it is not giving the complete picture. It is incorrect, right? So option B is wrong. Same is happening with the option C as well. It's coding for 362250 modifier. So at the same time, it is not mentioning about the right intracranial and extracranial angiography, sorry, right intracranial carotid angiography procedure. So option C is also incorrect. We are left with option A and D. So option A is coding for 36224 and 36222 with a 59 modifier. So let's review them. So 36224 is for a selective catheter placement of internal carotid artery. There was a intracranial carotid circulation angiography and extracranial carotid circulation and cervicocerebral branch arch done, right? So it's more suitable. It is covering the selective catheterization of right internal carotid and right extracranial and right intracranial carotid angiography, and 36222 is covering for a selective catheter placement of the common carotid artery, and it's also having extracranial carotid circulation as well. So with that, I would say option A is the correct answer, because option D is coding for a selective catheter placement into the common carotid and innominate artery, and that is for only intracranial, extracranial cervicocerebral branch. And 36222 is for a selective catheter placement into the common carotid and innominate only extracranial carotid, and it is also missing a 59 modifier here, right? So for our scenario, one of the catheterization was done in the internal carotid artery and the other was done in common carotid artery. In that way, also option D is incorrect. And the guideline also asks us to use a 59 modifier to denote different carotid or vertebral arteries being studied. So option D is wrong and option A is going to be our correct answer. Okay. All right. Okay. Thank you, Rowan. Thank you, Rowan, for letting us know that these sessions are helping you. Okay, I think we will cover one more scenario. Yeah, we'll cover this more scenario, this one, exercise number 4, and then we will conclude. So, go to of the following answers, which best describe the correct CPT coding for the catheter placement procedure? Option A 36200, option B 36216, option C 36216, 36217, option D 36217. A patient is taken to the angiography suite where under local anesthesia, catheter is introduced into the right femoral artery and advanced into the aorta. The fluoroscopic guidance, physician navigates the catheter into the right brachiocephalic artery and into the right common carotid artery, finally advances it into the right internal carotid artery. For of the following, which best describe the correct CPT code for the catheter placement procedure? And code as your time has already begun. Yeah, let's go. Michelle is saying, let's go, let's do it. Come on, chorus. You got this. All right, that is time. You can see the answers are still coming. Good job. Keep up the good work, coders. You all are doing a fantastic job. Amazing job. Okay, so let's break down the scenario. First of all, we have to get our inventories right. So we have a catheter placed into the aorta, and then it moves into the right brachiocephalic artery, right? Yes, from aorta, it moves into the right brachiocephalic artery, then it moves into the common carotid artery, and then into the right internal carotid artery. So let's see how it moves in from the aorta. So I hope this image will help you to better understand. So you can see it's the aorta. So if the catheter is staying in the aorta, that is for a non-selective catheterization. But in our scenario, it moved further and it reached brachiocephalic artery, and that would be your first order. And from brachiocephalic, it moved to the common carotid artery. So if it stops here, that would be the third order. And from here, still it moved further into another branch, that is the internal carotid artery. And it looks like this is a third order, right? So this is the path in which the catheter moved. So as per this image, which I'm showing, it should be third order. So we don't have this image during the exam. So what are we going to do for the exam? We are going to rely on the appendix L, right? So if you open your appendix L, you know that it is done above the diaphragm. So you go and look for those arteries above the diaphragm. So you have the artery reaching the aorta, and then it moves from the aorta to the brachiocephalic. Here we go. I've marked it. From brachiocephalic, where did it go? It go to the right common carotid artery. There you go. And from right common carotid artery to the right internal carotid artery. And that's where it stopped, right? So this is the path in which it traveled when you look into your appendix cell. And right internal carotid artery is in your third order. So you have to pick the code from the third order. All right? Yes. Now let's come back to the coding portion. 36200 is coding for a non-selective catheterization procedure. So it is wrong. Catheter went beyond the aorta in our scenario. So option A is wrong. Let's look at option B, 36216. That is for second order selective catheterization. Again, we had a catheter reaching till the third order. So option B is also incorrect. Now between option C and D, option C is coding for both 36216 and 36217. And 36217 is for the initial and third order catheterization. So yes, it reached the third order, right? But can we code both second order and the third order together? Can we do that? No, right? We cannot code that. As per the guideline, what do we have to do? We have to code only for the highest order till the last point where the catheter reached. And now a scenario, the catheter reached till the third order, and that makes option C incorrect, and the option D is going to be a correct answer. There you go. 36217 is your correct answer. Exactly, Sheila. Yes. Everyone's saying no, 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 yes, you all are absolutely correct. And I can see everyone went with option D. Fantastic job, coders. Thank you, Miss Veena, for letting me know that the cardiac catheterization procedure coding is much more clear for her now. So good to hear. Good to hear. All right. So the option D is going to be the correct answer. Okay, so let's quickly wind up by doing some poll scenarios. This is a hand poll. Let's refresh what we have learned. So we have few questions. This is a rapid fire question, coders. Type your answers quickly in the chat. Let's see who is having the fastest finger. So first one, what type of catheterization is this? Option A, selective. Option B, super selective. Option C, additional branch. Option D, non-selective. A catheter advances into the aorta and remains there without entering any branch. What do you think, coders? What do you think? Is this selective, super selective, additional branch, or non-selective? Okay. There you go. There you go. Everyone is answering. Yes, indeed. It is non-selective. That's what we learned today, right? Okay, next one. A catheter passes through multiple vessels and reaches the third order branch. What should you go? What should you guide? What should guide coding? Okay, that's forget it. So how will you code this one? You will code all vessels that is passed. Option B, vessels first vessel reached. Option C, highest order. Yes, the last scenario which I've seen, right? Excellent. You all are fast. Everyone's having super fast fingers. Excellent job, coders. Yes, we will code only for the highest order reach. Good job. Next one. Same vessels are studied on both sides, right side and the left side. What concept applies? Different territories. Option B, bilateral, same procedure. Option C, add-on code only. Option D, separate sessions. Let's say you coders. Same procedure done on both right side and the left side. Yes, it's the same procedure, right? So when the same procedure is done on the both side, you will use the bilateral procedure guideline. Good job. Let's move on to the next one. Okay, right side you have internal carotid artery study. Left side you have a vertebral artery study. What concept applies here? Option A, bilateral, which is the same, bilateral same, sorry, bilateral guideline. Option B, to different territories. Option C, non-selective. Option D, add-on code only. So we have in the right side, internal carotid study, left side, it's a vertebral artery study. So both are different territories, right? One is an internal carotid and the other one is a vertebral artery. Mm-mm. Okay. Yes. Great. Excellent. Yes, it's a different territory guidelines which you have to apply. Fantastic job, Coda. So how did you do today? Let me know. Let me know in the chat. Did this session help you? feel more confident about the catheterization coding. And if you think you need a little bit more practice guidance, that's absolutely okay. Because as I always say, mastery doesn't happen in one session. It happens with consistent learning, repetition, and with the right support. And here we are at AMCI, ready to offer you a right support which you need. And also coders, if you feel like you need more practice or want to revisit today's topic, you can head over to our AMCI YouTube channel, and inside the channel you will find a dedicated playlist called CPT Guideline Mastery over here. Okay, we have a lot of catalogs. In this catalog we have a lot of sections. Okay, feel free to go through each and every section, and if you're specifically looking for the mastery guideline session, CPT mastery guideline session, you will find it under the header CPT Guideline Mastery Sessions. And this playlist includes all our previous sessions recordings, where we have broken down different topics step by step in details. So take your time, go back, rewatch, reinforce your understanding, and I truly hope these videos will be helpful in strengthening the coding skills and boosting your confidence. I can see a few of you have already mentioning that it really helped. So thank you for letting me know. Also, please do fill out the survey form, because only if you fill out the survey form, we will know that these sessions are helping you. Okay, and we will be able to do more such sessions. So if you don't fill out the survey form, I will not be able to know that whether I'm doing a good job and these sessions are helping you or not. So please feel free to fill out the survey form so that we can come up with more such videos in the future. And coders, if you really enjoyed this video and learned something, please don't forget to smash that like button. Also subscribe our YouTube channel, and you will see a lot of contents coming your way. And share it with someone who needs to see this, who are preparing for the certification, or who are doing some doing some catheterization coding and need help. You can share it with them as well. So don't forget to fill out the survey form. Thank you for joining with us today. Thank you, Miss Catherine. Thank you, Miss Mills. And yeah, please, if you have any question, please do mention them in the survey form and I will get back to you. Okay, I've already again placing the survey form in the chat, so you can mention your additional questions over there. So thank you, Chorus. Thank you, Miss Mills and Miss Catherine, for helping me out in the chat. Thank you, team. Thank you, Chorus, for joining with us. We will be back with another session next week, next Friday, same time. Till then, stay safe, keep coding, and have a great weekend.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at